our conventions, but we have people on Zoom use the raise hand function to ask a question. We'll open it up for questions once Fiona has finished her presentation. So welcome, Fiona, and the floor is yours.
Tēnā koutou katoa, everyone. It's a great pleasure to be here, albeit virtually. I wish I could be in the room in person, but it's semester, so work continues. So I'm very grateful for the opportunity to talk about an approach to ethics that's very near and dear to my heart, and a concern for rural communities, which is also something I care very passionately about. So thank you again for having me. I'd like to begin by acknowledging the traditional custodians of the land. The photo on the left is my effort at from the Otago Peninsula, waiting for the little blue penguins to come ashore at Christmas time. So I'd like to begin by acknowledging the traditional custodians of the land upon which I work, walk and live. And for me, that's the Ningi peoples, the Turrbal and the Yagara peoples. I'd also like to acknowledge the traditional custodians of the land upon many of which you are standing, Ngāi Tahu, for most of you, or for many of you. I'd like to acknowledge elders, past, present, and emerging, and customs, laws, and creation spirits. And these lands have always been places for learning, teaching, and research. So, I thought I'd begin by talking to you a little bit about why I started the journey down this bioethics pathway. And it comes from, I had a collaboration with my colleague, Associate Professor Christy Simpson from Dalhousie University in Canada. And we were both mutually concerned about equality and equity, particularly when it comes to access to healthcare services and access to health outcomes. And one of the things that we were particularly concerned about was the rural context. Both of us came from somewhat rural backgrounds, and we were really conscious of some of the issues that patients were having and some of the issues that health professionals were having in these rural contexts, and how that relates to and affects one's ability to access care and access care in a timely way, in a manner that's appropriate for you. We were also really concerned about rural communities and rural residents and rural health professionals, for that matter, being positioned in a sort of deficit framework. They were being positioned as a problem in the context of the health system because, you know, it's expensive to deliver rural healthcare services because of the cost of the economy. People who live in rural communities are making a deliberate choice to know that they're not living in a place where healthcare is accessible, so we owe them a lesser duty or a lesser obligation than we owe the majority of the people who live in more urbanized communities or metronormative communities. It's problematized as a difficult place for rural health professionals to work. And it's also problematized as the place where health professionals who can't cut it in the real city practice go to work. So there's that deficit framing. And that can be really sort of problematic and can create consequences for the ways in which we and the ways in which people in rural residents and rural health professionals negotiate the healthcare system. And that impacts on policy, practice, service delivery models, funding, etc. So this led us to thinking about what could ethics do better to support rural healthcare. And thinking critically about what we teach in the context of bioethics and the presumptions that underlie most ethical approaches or codes of ethics. And so this is where our work in this space came from. So we were really conscious of the work of Salter and Norris, and they have said, quote, "The field of bioethics has relied heavily, either consciously or unconsciously, on the particularities of the urban tertiary hospital context for the creation of its most seminal concepts and practices, from informed consent to models of clinical ethics consultation." So they were drawing our attention to that sort of concept of metronormativity, that the norms are those that are experienced in urban care, and that much of bioethics thinking has actually emerged out of tertiary hospitals, and quite a lot of that in tertiary hospitals in the United States. And so the focus of some focus has been on the issues that are experienced in those contexts rather than the everyday ethics of practice experienced by health professionals who work in community-based contexts, and particularly in rural or remote regions. And so it got us to thinking about if approaches to bioethics are based on a sort of unstated assumption that you're providing care to strangers in a tertiary hospital, how do we negotiate the ethics of caring for neighbours in vastly different geographies, with different levels of supports that are available, with the tyranny of distance, sometimes the tyranny of poverty and other factors? And so we were asking the question, is it the same, or do we need to think about how to complement existing ethical norms with practice or place-specific ethical considerations? And we were wondering, and there's some evidence from the US particularly, that if the ethics we teach results in rural health professionals feeling a dissociation between what they're taught and what their code of ethics says, which again is embedded, we would argue, in metronormative assumptions or presumptions, and the realities of their practice context, is the nature of what is characterized as being a good health professional based on norms that are determined in the urban context and not the rural context. And so are we setting people up to go into rural practice and to immediately feel that the norms they may experience in their practice and the norms that they've been taught about and the ways in which they should approach ethical problems that they've been taught about don't fit? And so some people report in the empirical research that's been conducted in this space that they just feel completely out of place. They feel completely unmoored from ethics because it doesn't reflect the realities of their practice. And they face this significant concern that as soon as they go into rural practice, for example, there are issues with professional boundaries. That codes of ethics often talk about avoiding dual or overlapping relationships. And if you did that in a rural context, you'd never have any friends. Your children would have to be homeschooled. It's just inescapable in that context. So if your code of ethics is saying one thing and your experience is saying another thing, and your living arrangements say another thing, how do you negotiate that when you don't have the tools to do so? So, as I said, this might result in rural health professionals being feeling as though they've been set up to fail because they just don't recognize themselves in their practice context in the norms that they've been taught. And if the ethical norms of the professions are based on an assumption that everyone is caring for strangers, then the interconnectedness that often characterizes rural practice and rural communities is problematized from the outset. So often our discussion about bioethics is dominated by, particularly in the context of health professionals, by discussions of the principles approach that was developed by Beauchamp and Childress. It is obviously not the only approach, but it is one that has a fairly dominant role in the ways in which we have created codes of ethics, in the ways in which we teach health professionals. It's not the only one, but it's one of the ones. And as a starting point, we don't think it fully addresses or captures the complexity of rural practice. Again, this came out of a tertiary sort of situation in the US, as well as a concern about research ethics practices. And so we don't think it captures the complexity of rural practice particularly well, because it doesn't explore the differences between the care of strangers and the care of neighbours. It doesn't necessarily look at the individualistic norms that characterise at least some aspects of urban living versus the communitarian perspectives of rural and remote communities. who must depend on each other because there is a lack of services and service availability. And the relatively narrow expression of beneficence and non-maleficence in principalism that doesn't encompass a broad understanding of relationality. And so the implications are twofold, that principalism in and of itself is insufficient to support the analysis of everyday ethical issues faced in different practice contexts, recognizing that some people acknowledge that it has limitations in tertiary contexts as well. And there are sort of additional values that may better reflect key aspects of a specific practice context that might be necessary to employ and recognize and acknowledge to further support and enable meaningful ethical analysis and reflection in those contexts. So we approached our analysis drawing from critical feminist perspectives. And I might add, one of the reviewers from our book said, no one's interested in feminist perspectives. They had nothing. So that was interesting to receive as a review. But we do indeed draw from feminist perspectives. We're very interested and aware of power relationships and that power differential between rural and urban residents, and also between and amongst neighbours. Relationality in the context of community, and feminist epistemology, our identity as a function or creation of our past experiences, so where we came from, including how attachment to place or community can shape a person's sense of identity. And so that comes back to that old, you can take the person out of the country, but you can't take the country out of the person kind of saying. So all of these shape our identities as people. A few matters to acknowledge at the outset. Both Australia and Aotearoa New Zealand share similar experiences of conquest and colonisation. And the sort of dominant discourses in ethics come very much from the framework of the Enlightenment and perpetuate in some ways the norms of colonisation. So the rethinking that we propose in this context, with its focus on rural and regional and remote healthcare settings, doesn't suggest that we are trying to create an ethical framework for the governance of Indigenous peoples, who often are seen as living in predominantly rural areas, even though that's not correct. That's for the self-determination of Indigenous peoples. But we do acknowledge that bioethics needs decolonising, and all journeys need first steps, and in questioning some metronormative assumptions and assumptions about rurality, we're a small part of a broader conversation that is challenging normative assumptions. We also acknowledge that rural is more than, to quote Farmer, urban with trees and animals. It's heterogeneous. There's no one rural experience. And we also acknowledge that rural health professionals have much to teach ethics about the ethics of complex, interconnected relationships. So one of the sort of values that we suggest is really important in a rural context is relationships. And so we suggest that we need to revalue relationships in a way that is not couched in beneficence or autonomy. And so as an example, as I've said, professional boundaries, rural health care professionals often find themselves navigating overlapping or dual relationships, personal and professional. And oftentimes this is problematized, that this is an issue because it involves a boundary crossing. It involves the potential to overstep, overreach. It can cause conflicts of interest. It can negatively impact the therapeutic relationship. And so the norm, as I've said, is no overlapping relationships is ethically best. But what about if we frame that alternatively, and acknowledging that it is unavoidable part of rural healthcare practice, unless you've got a fly-in, fly-out service or a drive-in, drive-out service. If a rural health professional is based in that community, dual and overlapping relationships are unavoidable. And so they should be anticipated, acknowledged, and discussed, and revalued. one of the assumptions that we often build into this is that patients are automatically vulnerable. In the context of a community setting where there are dual and overlapping relationships, that may not be true in the same kinds of ways. The teacher of your child in school who attends you as a patient may have equal or more power over you than you have over them as a health professional, or at least it's arguable that in some contexts they will. So we need to think about how do we revalue relationships in that context and not just have this automatic setting, which is they're problematic. And we need to equip our health professionals with advanced and a specialized skill set to navigate those relationships. And these are skills that we argue that rural health professionals are forced to develop, because it is an everyday part of how they negotiate their practice. It can be a strength that can be leveraged for better patient care, just as much as it can be a problem and cause issues with conflicts of interest and boundaries and exploitation. And in rural communities in particular, we have to acknowledge the interdependence of people and caring with each other, for each other. We're not saying that all rural communities are cohesive, but we are saying that there is a certain degree of interdependence in a rural community, just because, as I said, of the lack of services, the need to travel for services. There are different ways in which boundaries are negotiated and renegotiated, different situations in which relationships arise, and different ways in which power is shared between members of the community. So power may shift in interesting ways in a rural context where you rely on others and when you have multiple connections. So we suggest that we need to revalue relationships and stop problematizing them in the same kinds of ways. We also have thought about the values of place. When we think about and talk about place, we're often doing that in the context of recognizing the importance and spiritual connection to place in the lives and decisions of Indigenous communities around the world. So this is well recognized and talked about. And the impact of that connection with place on decision-making is also acknowledged. So that, for example, in the Australian context, some Aboriginal elders will prefer to refuse treatment rather than being transported off country and away from their family and kinship communities. But we also argue that some non-Indigenous persons may also feel a connection to place, and that this too, for them, even though it lacks potentially that sort of spiritual context, might be an important element of understanding their decision-making processes and their needs as a patient. There's some literature around the connection between place and healthcare, but as Thien and Haenlin suggest, quote, much of this literature treats place as a mere backdrop or container of social activity. That is, meaningful differences in health are acknowledged to exist between places, but these are regarded primarily as a byproduct of other processes known to influence health. End quote. So we want to challenge that, because there is more research that indicates that place is much more meaningful of a concept in shaping some people, not all people's lives. And the research has examined this for rural residents, and there's some literature to suggest that those who live in rural areas have a stronger attachment to place. So there were found to be some statistically significant differences, for example, between some rural residents reporting a sense of belonging associated with physical geography than in the context of connection to urban geographies. Qualitative research also suggests that, quote, that rural residents, quote, imbue rural places with health-enhancing properties, end of quote. Other qualitative research indicates that rural residents feel more connected to land, and they may be reluctant to leave it, even if experiencing health problems. So all of these factors together, all of this evidence from the social sciences indicates that for some rural residents, place and connection to it plays a potential role in decision-making. And so we need to consider questions like, what does it mean to be dislocated or uprooted in order to access care? what does it mean to return to one's place, to die or to live out one's remaining years? What does it mean to not be able to do that and to feel that disjunction from place? And this is interconnected and intertwined with the concept of community for rural residents. So again, we suggest that community needs to be considered to be a value because, again, there's some research that indicates that community can be a part of the epistemology of the person. It informs and shapes who they are and how they understand themselves to be. And that again, there is social sciences evidence to suggest that some people in rural communities feel that community connection much more closely than they do in urban contexts. Again, this is not an absolute. Not every community in a rural or regional area will be united. Some will be fractured. Similarly, in some urban contexts, you will have communities that are very strong and interconnected. So I'm thinking here of migrant communities, refugee communities, Indigenous communities, and so on. But again, we don't necessarily value that part of community, except to say that, we need to engage with communities in the design of health services and health policy. But for some people, it's going to manifest in the obligations that they feel towards others in their community. And this could be based on a sense of solidarity. We're a rural community, we're a remote community, there's not very many of us, we have to stand together because if we don't, we'll all fall. So that sense of solidarity that we need to work together. Or it could arise from a sense of reciprocity, that I know that everybody in my community is really busy because we all depend upon each other. And I don't want to ask for something, for some assistance or some help, if I know that I can't return that assistance or that help in the future. Or that if I know that I'm going to overburden that person at this moment in time. And that sense of reciprocity, particularly, or that concern for reciprocity, particularly arises in the context of end-of-life illnesses, where that person knows that they're never going to be able to return the obligation, if you like, or the obligation as they may frame it. And so a greater reluctance, perhaps, to accept, given that they can't return, particularly if they haven't done anything to establish a bank of goodwill in the past. So again, what does this mean? It might entail asking more questions about what it means to not want to be a burden on one's community, to feel that one owes others some form of caregiving, to want to be able to give back in some fashion, and to lose connections to community if you must leave for healthcare. And how does that play out? How does that relationship affect healthcare decision-making? So again, you can see here, I guess, a theme here that we're emphasizing sort of relationships with people and between people, between healthcare professionals and patients, with place and how people negotiate place as part of their identity, and how people negotiate that sense of community belonging and community contributions that often arise for people in rural and regional and remote areas, and how all of this can affect their sense of who they are and affect their sense of how they make and why they make healthcare decisions. But it also is really important for us in a policy context so that we actually understand some of the drivers around care and concern and the ways in which we want healthcare services delivered in rural, regional, and remote communities. So the emphasis on community and our current discourses around health policy and health ethics are often around instrumental conceptions, as I said. It's a means to an end, a way to achieve health-related goals rather than being a value in and of itself. And some of you might say, well, you're idealizing community. Absolutely. For some people, though, the concept of community has intrinsic value and is in part constitutive of their identity. And so it is really important. So we would argue that if it's part of their identity, it's part of their epistemology, then they might take the further step of having community as a value that forms an explicit or implicit part of their decision-making process. You know, it's another form of relationality in the sense that you're tempering your decisions around the impact it has, not just on your family, but also in the community that is tight-knit and dependent on each other. So it might manifest in what might loosely be termed the obligations they feel towards others in their community. And that could be grounded, as we said, in solidarity, in reciprocity, or both. So consider how assumptions such as everyone knows everyone or rural communities take care of their own influence decisions about patients coming back home, allocation of health resources for community supports, and perceptions and expectations around confidentiality of privacy. And I guess it's important to note here that we also highlight not just the deficit perspectives, but the perspectives of rural utopias. There's a great deal of expectation that rural communities will look after their own. And so in some ways, neo-capitalism has taken advantage of that, because that hollowing out of state support and state services has been accompanied by a presumption that the community will rally together to support other people in those communities. And so that positive presumption of community can also be used as a justification in a health policy circumstance for the hollowing out of resources and resource care, and putting further burdens on rural residents to look after each other, to have systems of reciprocity or solidarity to enable access to care. So message. We think context really matters. We think context really makes a difference. And we think context makes us, makes it really imperative to rethink what it means to provide health services in rural communities and what this means, particularly for rural health ethics. There's value in naming, discussing, and addressing ethics issues in these settings, and we need to help reshape and inform traditional approaches to ethics and expand the rate of what is considered and utilised, as well as what is taught. There are many lessons that rural health professionals can teach us, and rural communities can teach us, particularly about much more nuanced and sophisticated ways of managing relationships and the complexities of relationships with people, place, and communities. So if you want to read more about this, we have a book, Rethinking Rural Health Ethics, and we also have this chapter in a book where we talked about how this informs our approach to teaching of bioethics. And I'm happy to take any and all questions, and I think I managed that in half an hour, so we've got lots of time.
That's fantastic, Fiona. Thank you so much. Just to say again that if you're joining us via Zoom and you have a question for Fiona, please use the raise hand function on Zoom so that we can see that you'd like to ask a question. Perhaps someone in the room can unmute the Bioethics Centre for people who are joining us from there, and we can take questions from the centre seminar room as well. So does anyone in the centre have a question? I just can't see.
Oh, I have.
Thanks,
Thank
Grant.
you very much. That was a wonderful talk. And I'm particularly thinking of its connection to the fact that after you've had a major health event and tried to rehabilitate, what is really important to you, speaking from first person, is getting back into the rhythms of your life. And those rhythms of life take place in a context, like any rhythm in a piece of complex music. And I think we as university centres and academic contexts can really work hard, particularly in this age where university collegiality is threatened as never before, to create a context where not only people, but also university people can learn a lot from the neglected rural health context that you've pointed us towards. I wonder if you agree.
Most definitely, I agree. I think there are lots of learnings that we can get from the rural health space and return them to sort of our urban sectors, which have lost, I think, a lot of sight about the patient as a person. There's a lot of talk about person-centered care, but there's not much action into person-centered care. And there's also not much recognition necessarily of all the threads of that person and how to restore those threads for when they depart. So I think there is an awful lot we can and should learn to improve healthcare across the board.
Thank you.
Fiona, I have a question for you. So in some other work, I've looked at rural and underserved communities, particularly from the perspective of foreign trained health professionals who tend to practice more in those communities and often quite critical to the provision of services in those communities. I wonder if you have looked at all in your work at the experiences of foreign trained healthcare workers in those communities, which can be quite difficult to navigate, both from the point of view of the providers and perhaps also the point of view of patients, and what sorts of ethical concerns that might raise?
Yeah, that's a very good question and a very complex question. In part, what we see is that the overseas trained practitioners are often positioned in that deficit narrative, which again is you're not good enough or you're not wanted in urban practice. And so we put you in rural practice for a limited amount of time until you're good enough with our system to come back into urban practice. And so there's that immediate positioning in this and framing of overseas trained doctors as being a deficit, part of that deficit, part of that, oh, we've got to throw you a bone, so here we go kind of approach. What we also find is that depending on where the internationally trained graduate comes from, they actually may have many more skills for rural practice, in that they come from contexts where relationships and community are much more important. So they may have those skills to navigate those contexts in ways that someone who's trained in Australia or New Zealand may not have. The other issue that has been particularly seen in the Australian context, and I don't know about the New Zealand context, has been the degree of stigmatization of some doctors and nurses by the communities. Oftentimes the community is just really grateful to have a healthcare professional and go out of their way to make that person become, and their family to become, part of the community. But sometimes the difference in cultural norms and the difference in kind of professional practice norms and so on results in a fair amount of stigma directed or discrimination directed against that healthcare professional. And that has been a significant issue, particularly in some parts of Australia, that there's this automatic sort of suspicion. But then there is some parts of Australia where international medical graduates or international nursing graduates are preferred because of the ways that they can fit in with communities better. So I think there are some significant issues that need further exploration there, and how this impacts on both the sort of deficit and framing, but also the framing of what it takes to be a good doctor or nurse or etc., and how that is negotiated in different cultural contexts and different contexts in terms of urban and rurality. I'm not sure if that's a satisfactory answer, but that's where we've got on that question.
Yeah, absolutely. It's such I mean, my research on that has been based largely in rural communities in the US, where the bias and discrimination issue has been a significant one.
Yes.
So it's just interesting to think about what those practitioners might need to support them in their work that's very different from what you might need if you were in an urban environment with perhaps less of that or more support from a wider community.
And I think often when we talk about international medical graduates, the focus is induction into the system. The focus is not induction into the community and the community expectations and ways of doing things. And so I think that's a missing part and a missing piece. And the communities where health international graduates survive and thrive tend to take that community orientation part very seriously. The communities where they don't, it tends to be more, oh, here we go, another second rater coming in, deficit, and that impacts on the way in which that person is the relationships build.
Absolutely. Thanks, Fiona. Eileen, go ahead.
Thanks, Elizabeth, and kia ora, Fiona. Thank you for a wonderful talk. I really enjoyed that immensely. And I wondered whether you could just expand a little bit more on the idea or how to kind of resolve this nexus between relationships that you were talking about, where there's kind of a bit of a blurring there between the professional and the personal, and that whole issue of confidentiality and privacy. Could you offer a few more comments about
yes.
This is a tricky area, isn't it?
Yes. So I think I might separate those two out because I think the issues around boundaries and the issues around confidentiality have slightly different threads. So start with confidentiality. Our experience of working with rural communities is that the issues of confidentiality are complex. The general, for some people, there is almost a presumption that everybody in the community should know what's happening in terms of their health, so that someone can show up to milk the cows, right? So that you don't necessarily have to ask, but that system of solidarity or reciprocity care will kick in without you having to do anything, because everyone should know where you're at so that you can work together. Some rural residents, though, have the traditional expectations of confidentiality and privacy, that it is maintained stringently. And again, that comes back to some of the stereotyping of rural communities, but also the reality of some people's experience of rurality is the sense of stoicism and self-reliance, that you are seen as weak or seen as not good enough if you are sick and you do need help. So there's that complex mix of that. What some have suggested is that certain types of healthcare interactions attract stronger obligations in respect of privacy and confidentiality than others in the rural context. And so that is negotiated based on almost the sensitivity and the gravity of the interaction. Those types of things need to be more tightly held until the person indicates it's okay to loosen it. But that for many people, a little bit more looseness around sort of everyday care or etc. Is what they expect to enable their community to function. Of course, this depends on the community itself being a functional community. it's quite different if the community is fractured, where obligations around privacy and confidentiality are much more similar or stronger than those in which we talk about traditionally. Does that kind of answer as much as one can?
Yeah, no, that's great that you've teased that out a little bit more. And I'm thinking around things like mental health, of course, where
yes. And that is the one where there's the greatest sensitivity.
Yeah, it's that thing about kind of potentially stigmatizing
that's right.
conditions that perhaps not all of us think are stigmatizing, but the
yes.
majority view might be, or it could be procedural things. And I'm thinking of terminations in that area too, where
methadone is a big one. So
yes,
access to methadone.
so the addictions, or yes,
yep.
that's right. Yeah, so I think that you have been able to explain that really well. I mean, again, it's a bit of a blurry area, isn't it? A blurry space, but the idea that there might be some movement in it as well, and a general goodwill of trying to help people when it's necessary.
And I think this just points to the need to do further work, because this whole space is to a certain extent blurry, where the expectations of the community and their needs are not necessarily addressed in the way in which we formulate and teach bioethics traditionally. And so that leads me to the second bit of your question, which is about professional boundaries. This is a complex one, and we're currently working on a paper on this issue, because there's been some interesting disciplinary cases come out of Australia recently around rural health professionals and so-called boundary issues. And I'm not talking about sexual boundary issues here. I'm talking about the issues around providing care and treatment to family. And so there's been some interesting case law that's come out recently that's held a really hard line against you must never provide care to family. And then you've got the health professionals saying, well, my husband or partner or whatever has a really significant condition. If he doesn't see me, it's like 4 hours down the road. And he's really sick. And so what is the problem? That these expectations that you don't provide care to family, obviously there's an emotional component to that. Yes. There's the potential for abuse in that, drug addiction, et cetera, but there's also that piece of it, which is if I don't do it, what's going to happen to the person that I love? And how do I negotiate those kinds of aspects of it? So one of the things that we're thinking about is, can context suggest that it's more than the need for emergency care that you should be able to provide family members, as long as you do it consistently with good medical practice in terms of how you document it, how you assess it, etc. Are there ways in which we can better allow that kind of grey to be explored, to be nuanced, and to be not subject to the binary, this is not okay, at the disciplinary level?
Fiona, have they considered the role of supervision in that as well, professional supervision?
No, it didn't come up. And I think that again is another important facet that is in our paper, which is not just in accordance with good medical practice, appropriately documented, etc., but also cross-checked. So you say, okay, I've done this, but I'm just going to call in to make sure that everyone is happy with that as an approach. Yeah. And telemedicine can also perhaps deal with this, but it doesn't seem to yet. And that could be because in all our countries, there's still areas where internet is very dodgy indeed, where there's no mobile coverage and where things get much more complicated and complex.
I've got a question, Elizabeth, from the room.
Oh, okay. Thanks, Simon. Go ahead.
Thanks very much, Fiona. Simon Walker here. I think we've met at an ARBL meeting.
Yes.
Thank you for this talk. It's very interesting. I'm just thinking about the broad project. It seems to me that a lot of what you've said could be reframed as rethinking ethics. So
Yes.
the points around place and power and
Yes.
all of this should be thought about in every context where we're doing ethics, I think. And then you've highlighted some things about a rural context where our starting point might be different from other areas, or there are particular values that will have higher priority.
Yes.
I suppose it's more of a comment just to see how you feel about that, but also
Totally,
yeah,
totally agree.
Right.
I think that one of the challenges that faces health systems and faces bioethics really is that we have moved away from that sense of relationships as being really important, and from people as being important. We talk a lot, as I said, about person-centered care, but we are still faced with a situation where essentially some people believe that their responsibility for the patient ends at the doorway when they exit, where they're seen more as a throughput issue rather than a person who's got a complex life that they need to be able to return to, or a complex life that affects the way in which decisions are made. So, and we also have a system where health professionals do get to know their lives of their patient more in, for example, primary care, for example, in addictions, mental health, and so on. You may have contexts where you have a far greater awareness of the patient and the complexity of the patient and the complexity of the sort of community place nexus. And so that these kind of debates, we think, have a resonance in those particular practice contexts as well. Absolutely.
Thank you.
Thanks, Fiona. Thanks, Simon. So we have a question from West Coast IPE.
Yes.
Go ahead.
It's Kerry here from the West Coast IPE program. I'm intrigued because in a small community, our loyalty is more to our people in a way than our professional bodies, and also, I suppose, the system. Because if you don't have a relationship with your patients, you can't really have a therapeutic relationship with them either. So
absolutely, yep.
Discussions in the practice about how we sort of keep someone on board to manage them, even though it's perhaps not in a way, perhaps a less usual way of doing it, because you've got to keep them attached somehow, because there's nowhere else for them to go very easily, but we've got to somehow maintain a relationship for perhaps some other condition we might be dealing with them over. But it's very complex, and I'm really pleased that people are thinking about these things, because in a Maori context, the relationship and forming connections is essential before you can do anything. But I would say that in a rural context, that's important to people who are non-Maori as well, because they like to know how you fit into things, how long are you going to be here, are you sort of worth getting to know, just flying in and flying out. And I guess that people who come in and work perhaps with the Transalpine health system, who come in, maybe do a week and then go away, they perhaps don't see that the same. I'm not really going anywhere with this, so just sort of as a train of thought that the relationship is important so that we can actually have a therapeutic relationship down the track should we need one.
Yeah, absolutely. And one of the sort of issues that we discuss in the book is that there's some research that suggests that rural residents, let me reframe that, that there's a lot of work that has gone on and is going on around, quote, rationalizing service delivery. And so here in Australia anyway, there's a lot of talk about hub and spoke models and closing down some services like maternity services in particular areas because of safety concerns, ostensibly, as opposed to cost. There's some research to suggest that people in rural areas would be willing to have services that that are more local, even if there is a slightly higher risk of negative outcomes. And in part, I think it resonates very strongly with what you were saying, which is because they have trust.
Mm.
They have trust in their local health professionals because those local people know them. They know their family, they know their situation. They're inside their community. And so that result speaks really strongly, I think, to reinforce what you were saying there about the need to have those kinds of relationships in rural communities between health professionals and health providers and patients, because it does depend on trust and not trust in the abstract, trust in the person, in their role in that community, in their role as a professional. So the layered trusting of the person.
So really training people, or giving them advanced skills by, say, taking the practitioner away to give them some advanced training or rotation through a certain service, but retain them in their rural provincial setting with enhanced skills is better for everyone, because you've got that person who's in the cricket team, or goes to the clubs, or the kids go to school, so they actually understand the community.
Yes, and what we face though is a tension between what is better for the community in terms of what they are willing to accept, what they need, what they want, and vis-a-vis what people who are quite concerned about risk, who are quite concerned about legal consequences and so on. And so there's that constant negotiation between the sort of apparatus of the healthcare system, if you like, with its risk-averse sort of criteria, vis-a-vis the question of what is best for that community. Yeah.
Thanks again, Fiona. Roger, go ahead.
Hi, Roger.
Hi. Hi, Fiona. Great to see you again. And thanks for an excellent presentation. I have a few comments. The first is to reinforce.
I'm sorry, Roger, but it's very hard to hear you.
Strange.
There's just a bit of interference, perhaps, in your microphone, Roger. It's just making your voice a bit distorted.
Let me try a different microphone and see if that works better.
Should we pause? Roger, do you want to see if you can adjust your microphone?
Better?
That's better. Yes, go ahead.
Yes.
So, right. So you can hear me better now. Is
Much
that right?
better. Yes.
Yeah. Okay. What I was saying was that first of all, reinforce the comments you made about relationships. I was a rural GP for a number of years, including GP anesthesia, and when I found I was going to give an anesthetic to a person who I knew through more friends, friendship connections, and including children, if I got anxious that they might think, well, I'd be better off with a specialist anesthetist. But I found that actually people were pleased that it was me because they knew me and had confidence in me, and that actually made the whole process a much smoother one. So just to reinforce that relationship thing, and then a couple of ones that are more conceptual, I guess. The first is the notion of expertise. So as you know, if you're others, I've been involved for many years exploring social accountability. So that's the focus on healthcare and education, on addressing the health needs of people who are being served, and that leads to community engagement and the notion of community engagement being an interdependent partnership. So that people living in their home family community setting are experts on themselves, and that expertise should be valued as being of equal importance to the expertise that might be in the academic institutions or in the big subspecialty hospitals and so on. So I'm interested in your thoughts on that. And then the other conceptual issue is, what you've described as a sort of utilitarian black and white sort of ethics developed in the in the subspecialty hospital setting, do you see virtue ethics as maybe a way of making the connection to the importance of context?
Okay, so let me start with the first of those questions, I think, which was about individuals within communities knowing best and communities knowing best. Absolutely, I think that's really important. And one of the chapters in the book talks about the need for engaged communities in governance processes to strengthen conversations about what is really important for that community and why and how, and also around making health professionals who come from outside that community feel welcome and integrated into that community as a form of retention, etc. So extremely important to have those engaged communities in the governance processes, as well as just as patients, if you like. The second question was about totally gone out of my head now.
It was about virtue ethics.
Oh, that's right, virtue ethics. Do I think that virtue ethics is a way to compensate? Well, yes, in a sense, because what we have as health professionals saying, the things that I was taught don't really fit. So I'm going to do what feels right, that feels best for my patients, that best meets the needs of my patients because of the virtues that I'm trying to cultivate as a healthcare practitioner. So that's your ideal piece, and that's certainly what some report as their response is, that they sort of develop a new frame of practice based on their care and compassion for their particular patient group or particular community with whom they're providing services to. Others report an absolute fear of departing from the norms in which they've been trained. So assuming that, let's just say they were trained in a sort of principles framework, but they also look at the codes of ethics and etc., good medical practice and codes of conduct and so on. And they don't see themselves or their practice reflected in there. And so some of them become risk averse and very conflicted and face quite a lot of moral distress over, what do I do? My patients seem to want me to behave in these kinds of ways and interact with them in these kinds of ways, but all the official documents about how I should practice ethically and professionally are telling me to do something else. And some of them don't have the confidence to fall back on that sort of virtue ethics framework because there are risks to that legally. So it's the risk averse people, I guess, who are less likely to make that evolution into saying, I just need to do this the way that's best for my patients. Is that... Thanks, Roger, and good to see you.
Yeah.
Thanks, Fiona.
Great.
We've just got time for one final quick question. Rosalie, why don't you go ahead with your question?
Sorry, it's possibly more of a sort of discussion or statement than question. So I'm a rural generalist, working and living in a not tiny community, but a small community in a hospital context, and I think that concept of the different relationships and the fact that often we'll have patients that have where more than one point of connection to is really helpful. I also like that neighbour analogy, because I think there's a continuum of how well we know people, whether they're close friends or whānau, or whether they're someone we know for our kids or for another social point of connection, but they're not someone who's close. And I think developing tools to help people work out where patients are on that continuum, and then when it's appropriate for them to provide care and not. And it also depends on the time of day. Like there's certain times of the day where I am the only doctor on for the whole, region of 3,500 people. It's me, and that's it. And then there's other times when during the day we have a second doctor on our ward, so I could ask my colleague to see them, so I think having some tools to help people sort of work out where on that spectrum, and are they more neighbour or are they close friend? Because we don't always have in urban contexts, often it's much easier to,
Yes,
hand them
exactly.
over.
Yes.
So I think that's something I've actually just sort of been thinking for myself. So that's been very helpful. The other thing is I've also thinking about how people in communities get care for themselves, and that they can still access care as health professionals.
Yes.
And I mean, you touch on that with the confidentiality and things like that. But and there's some things where, I mean, I personally drive an extra 20 minutes to see a GP and to take my kids to see the GP, because
Yes.
when I first started, I was a GP and we were all doing peer review together. So I preferred to, sort of see someone outside of that, but it's still, they're still within our wider catchment area. And, so it's, and if I had to take my toddler to my own hospital in the middle of the night the other night because he had, breathing issues, like, so you can't not have those points of contact. And I think, and even in bigger cities that does happen, but I think it's so much more so in our rural communities, and we need to have a way to deal with that. So thanks very much for your work. Sorry, that's probably a bit rambly, but
no, absolutely. Thank you so much. Yes, I absolutely agree. We need to do far more work on the complexities and nuances of this and give people the tools, and also to have those tools reflected in our sort of primary statements of professional and ethical practice, so that disciplinary actions against people for not obeying, for not being compliant with rules that actually aren't fit for their practice context, that sort of nuance is recognised and acknowledged by the legal system.
I think the Medical Council New Zealand is currently consulting on providing care for those close to you, and I have to say I haven't caught up with those documents, but I'm hoping that there's something in there to sort of help gauge how close is too close, because it's just unworkable to say, well, if you know them socially, you can't, be their doctor. Yeah.
And I think the advantage of Aotearoa New Zealand is that despite Aotearoa New Zealand becoming sort of increasingly urbanised, the rural context is still visible enough and connected enough that these kinds of issues are more visible to policymakers. I think when you're looking at the sort of vast countries like Canada and Australia, there's less visibility about this in the medical, council context, or the Medical Board of Australia context. So out of sight, out of mind, in a sort of different way. But it's really important. Thank you.
So we are unfortunately out of time, but thank you. A very big and warm thanks to Fiona for joining us today from Australia, and also for sharing such interesting research. I think there's really a lot to think about here for bioethics in general. So thank you very much, Fiona. A big round of applause from all of us virtually, and we look forward to seeing you perhaps at ASBH. Sorry, not ASBH, at ARBL in November when we come over. A number of us are coming over to Brisbane for that in November. So thank you very much, and thanks to everyone for joining us today.
Thank you.
Thanks, Fiona.
That was great. Thank you.
Thank you. Bye.
Thank you.
See you soon.